right, everybody. I think we're going to go ahead and get started. Thank you for joining January's Grand Rounds presentation. To kick the year off, we are going to hear from a personal favorite. He's relatively new here at Insight. It's been, I think, 3-4 months or so. Got the coolest name in the building, Dr. Evan Peskin. So feel free to take it away.
Thank you, Evan. I appreciate it. It is an absolute pleasure to give grand rounds. That's right. I've been at Insight for about just around 3 months now. I'm enjoying it immensely. Great people to work with. And I am extremely honored to give this grand rounds. It's my first and hopefully won't be my last. So when I was asked to give the grand rounds, there was asked what topic I want to discuss. And after looking through a lot of different things, I feel like the most high yield and interesting topic is back pain. It's something that a lot of us can relate to. It's something that is incredibly common. So this presentation is made for all levels of understanding, all levels of specialty, and hopefully it's something you'll find interesting. So again, I'm Dr. Evan Peskin. I'm an anesthesiologist and a pain specialist. And this is a talk about acute and chronic low back pain. I'm going to do my best to go through this incredibly expansive, complicated, nuanced topic in 20 to 30 minutes. So we'll do our best. All right, start this up. So disclosure and disclaimer, I'm not being paid for this. There's no relevant consulting endorsements, partnerships that I need to discuss. I own and claim ownership none of the images that are used in this presentation. And this presentation is meant for general information and education. You shouldn't be making formal medical decision-making by yourself off this material. It should be done in partnership with a medical specialist. And most important for me is life and this topic are serious enough, so I do my best not to be. So this is one of my favorite pain textbooks. It's Bonica's Management of Pain. It is a big structure that I used for the presentation. So between acute and chronic, let's start with acute back pain. So when you come to acute back pain, there's 3 questions to address. First, is it acute and back pain? Second is what kind of pain it is. And third, are there any serious pathologies that are leading to it? So the International Association for the Study of Pain, the IASP, is one of the large and most sentient bodies in pain. So they defined chronic or acute lower back pain as pain arising from one of the components of the lumbar spine and referred to it as lumbar spine pain. When you talk about the actual outlines of the physical space, it's laterally between the margins of the erector spinae muscles. Superiorly, it starts at the last thoracic spinous process, T12, and then at the bottom, at the tip of the first sacral spinal process, or S1. Is it acute? So the IASP set the upper limit of this time and defined acute pain as pain that has been present for no longer than 12 weeks. When you talk about the kind of pain, there's somatic pain and there's radicular pain. Somatic pain is that kind of like dull, diffuse, aching, broad pain that you have. The center is relatively fixed, but it's hard to take one finger and point to the one place that it is. It's often muscular, skeletal, tendon, ligamentous contributors, whereas radicular pain is this sharp, stabbing, shooting electrical type pain that travels in a path, usually this narrow strip from the back, usually down the lower extremities when we're talking about lumbar radicular pain. The mechanism is secondary to the irritation of either the dorsal root ganglion or the body or aspect of the spinal nerves or spinal cord. And then referred pain, the idea that where you feel the pain may not be exactly where the underlying problem is. We're all familiar with the idea of a heart attack, you have the pain and pressure in your chest, but people describe this sharp pain in their left shoulder or pain going up their neck or down their arm. So referred pain, we look at all the different contributing nerves, and you look at first order, second order, and third order neurons. First order exists in the peripheral nervous system. You can think of it like running down one of your extremities, the peripheral nerves in your leg or in your arm. They join the second order neuron in the central nervous system, which is the spinal cord, and reach up to the third order neuron in the brain. So when you say lumbar spinal pain, that doesn't necessarily restrict the full location of the pain, because you can still call it lumbar spine pain and feel it in your leg, but where it appears to start or where it's primarily perceived. So you have this convergence from somatic referred pain, which is the second order neurons that I talked about starting in the spinal cord, can get input from multiple first order neurons, both from somatic structures like muscles, tendons, ligaments, as well as deep structures, the viscera, like your GI tract or organ system. That's why when you have pancreatitis or you have infection or irritation of your gallbladder, it's referred pain to shoulder pain, stomach pain, back pain. All of these things can kind of converge together on single second order neurons, and your brain perceives it from coming from the same area. So here are some zebras or less common things. We're all familiar with the phrase when you hear hoofbeats, you think horses, not zebras. But in medicine, you need to be considerate in thinking of zebras. So there's extrinsic causes that can be irritating it, like hemorrhage or inflammation that's irritating the anterior surface of the spinal cord in the lumbar spine. For people who have ruptured aortic aneurysms, a lot of times, sadly, one of the or the only presenting symptom is sharp, sudden stabbing back pain. And it's hard to distinguish that back pain coming from muscle or nerve being irritated or a ruptured aneurysm inside your abdomen with the blood irritating this space. So intrinsic factors like fractures of the lumbar spine, primary tumors or metastases, and infections of the area can also be contributing. So these are words that are thrown around a lot, and they sound very similar. So there's spondylosis, spondylolysis, spondylolisthesis, and they all mean different things. Spondylosis is degenerative changes of the spine. Spondylolysis is a fracture in the pars interarticularis or articularis, which is pointed with the arrow in this first picture right here. And spondylolisthesis, which is displacement of one vertebrae over another. If you're looking from the side, usually the vertebrae line up, but damage, a lot of times secondary to spondylolysis, can cause the vertebrae to slide either forwards or backwards relative to the vertebrae underneath it. Something that's important is that these things can occur commonly in patients without back pain. So this finding on imaging, X-ray, MRI, CT scan, does not mean this, you've identified the one single cause of the back pain. It means it could likely be contributing. It's possible to be contributing, but the finding alone is not diagnostic. There are many algorithms that are shared for acute low back pain, and there's different societies, different publications, some updated, some not. And at the end of the day, the most important thing when treating back pain is asking questions and doing a good history. Where does it start? Where's the distribution of the pain? How often does it happen? Is it constant? Is it intermittent? When did it start? Were you riding a motorbike and then all of a sudden after that you have back pain, or it built on slowly over 10 to 20 years? Associated features. Do you have weakness? Do you have numbness? Does the pain stay in the low back? Does it radiate down the legs? And you look for an event, an identifiable cause. I had no back pain and then I had a car accident and now I have back pain. It's a pretty clear indicator of something happened there. It is our absolute duty to be aware and be thinking of red flags, things that, like I said, back pain could be a muscular sprain, could be a vertebral fracture, and it could be, unfortunately, in some people's cases, a tumor. Doesn't mean one is the cause. It means you have to be aware for these red flags. So for fractures, you look for some red flags associated with fractures. The most common contributing aspect for fractures are trauma and then prolonged use of corticosteroids. So if the individual is a very muscular 89-year-old person who starts for the Lions, you should be thinking fracture. You have to be aware of other red flag findings like weight loss, a personal or family history of cancer, and then presence of neurologic features like numbness, weakness, loss or altered control of bowel or bladder function should immediately kind of be at the front of these kind of exams. And there are different indicators and different tests that can work up for each of these individual findings and considerations. Something that's always asked is, I have back pain, should I have gotten an X-ray? Should I have gotten an MRI? When do I get a CT scan? It's, especially in acute pain, something that is less indicated and less suggested. So plain X-rays lack sensitivity and specificity, and it's only really used for people who have a history or reason to have fractures. So medical imaging can alarm people, and it's something that I had referred to, and we'll talk about in a second, that a finding on imaging does not mean you have found the cause of the pain. So one of my absolute favorite studies in pain is from 1994, and it's a study that was done where they did an MRI on 98 people who have never had back pain in their lives, and there was a variety of ages, genders, backgrounds, histories, but these 98 people had never ever complained of chronic back pain or even acute back pain. Doing the MRI, only about a third of them had no disc protrusions. So 2/3 had abnormalities in their lumbar spine, in the joints, in the discs, in the associated tendons. So even people, even some of us, not me, but people who are lucky enough not to have ever had back pain, that doesn't mean your imaging of an MRI or an X-ray would be completely without findings. So a physical exam is important in acute back pain. Unfortunately, there's very little evidence of specific findings or physical signs as an identifying cause, but the absence of any somatic signs, like that general diffuse pain, means that you should be higher consideration of underlying neurovascular or internal visceral structures contributing. So again, inspection, you look for abnormalities, palpation to feel if there's altered sensitivity, if there's specific areas of tenderness, and then movement testing, active and passive range of motion, inflection, extension, bending. However, nothing that's found on any of these particular maneuvers reliably can point to one single thing as the cause of the pain without any variability. Initial management for acute back pain is you need to consider and discuss if someone's hurting, if they can't move as well, if they can't work. Why is Dr. Peskin talking so fast? These are things that need to be addressed and considered. Medications have no proven place in the management of acute back pain. When they've reviewed and studied all the individual medication families, muscle relaxants were slightly better than placebos, but only for a matter of days, and it comes with significant side effects. Superficial heating is cost-effective and better than placebo, and maintaining activity is a crucial component to prevent decompensation and worsening of the pain. There's no evidence, there's no published studies that show cold bed rest, TENS units or stimulation have significant impact on the pain and can also conflict with the idea of patient empowerment or the fact that they have impact in their own outcomes. So more management, all guidelines suggest returning to work, remaining at work, possibly with modified duties. Discuss the fact that most acute back pain has a favorable natural course when you've ruled out red flags. Very important is it's wonderful to make sure that you have follow-up with these patients. Just because someone comes in for acute back pain and then you send them out and don't see them again, that doesn't mean the back pain got better. That just means you didn't do a great job of following up. And discuss red flags and also red cards and red dawn and red versus all these other things as well, but discuss red flags in acute back pain. So that's acute. So let's talk about chronic back pain. Chronic back pain is an enormous problem in the United States. 8 out of 10 people, Americans specifically, will have back problems at some point in their life. It's something that has cost about $50 billion that Americans spend on back pain every year and has led to 150 missed work days overall in the US. So 4 aspects to address for this, whether it's chronic back pain, if there's referred pain, any red flags, and trying to identify the underlying cause. So is it chronic and low back pain? We discussed already the rubric for low back pain and the specific muscular structures and outlines. So that's the same thing as the acute pain component. And if you're wondering if I copied and pasted this slide, I did. That's a good eye. So then is it chronic? Is it something that has, by the ISP definition, lasted longer than 3 months? You can consider working it up earlier if there's no improvement or no change from the initial presentation. So what's the cause of the chronic back pain? There's multiple things that could be contributing. There's noxious stimulations of muscles, ligaments, the individual joints, variety of joints, the spinal cord itself, the nerves, the peripheral nerves, the discs. There's many things that can all present with pain in this specific area. Back pain can also be by mechanical or chemical irritation of the lining and the surrounding area of the spinal cord. And notably, theoretically, the most significant and tender area that leads to this is intervertebral disc stimulation. So the intervertebral discs, it is the soft cartilaginous padding between the individual bony vertebrae of the back. So disruption, not just generation, can also cause pain. There's different fissures, either concentric, running around the annulus, radial, perpendicular through it, or transverse along the thickness of the disc. So stimulation of this area through inflammation can cause pain of the disc itself, the nerves that innervate it, or the end plates of the vertebrae that are touching this area. There is the lumbar zygapophysial joints, which, and luckily I have my little presentation material right here are the joints between the individual vertebrae of the back. Each individual vertebrae has two joints where they articulate with the vertebrae below and two from the one above. So swelling, irritation, inflammation of this joint can lead to this referred pain, but there are no good studies that show any antemortem or pre-death methods of diagnosing these injuries as the underlying cause of back pain. Multiple studies have shown that, spondylosis or spondylolisthesis occur in equal prevalence in people with and without back pain, something I'd referred to before. And these degenerative changes only occur slightly more frequently in people with presentations and complaints of pain than in asymptomatic patients. It is something that is just naturally inherent to aging. So modic changes is something that can occur in the spongiosa of the vertebral body above or below the disc with disruption, inflammation, or irritation. There's type 1, which is usually the more acute phase, and type 2, which is the chronic resolution leading to post-inflammatory symptoms with fat deposition and localized changes. There are high intensity zones, which represent cross-sectional appearance of a fissure, which does, in studies, in theory, lead to a more reliable identification of this disc being the contributing source of pain. So the same approach for acute and for chronic, a good history and a good exam outlies and outweighs any specific imaging or other studied assessment. So you assess, and then you assess again. The site, can it be referred pain? What sites are contributing to this area? Duration, is it actually chronic pain? Distribution of it, is it staying in the low back? Does it radiate down a limb, which says, is it radicular or is it somatic? The quality of it, is it dull diffuse? Is it sharp electrical, showing is it radicular or is it somatic? The intensity of it, is it radicular? And I'm kidding about that. That 1 through 10 does not indicate one versus the other. It's just a severity of how painful it is. Are there associated symptoms like night sweats, weight loss, fecal or urinary incontinence that should immediately set off alarms as something that needs to be worked up? Was there a circumstance? Was there a fall, an injury, a car accident, etc.? And was there contributing social or psychological factors leading to this? So once you're done assessing, you assess some more. Your physical exam, just like we talked about, looking for neurologic weakness, tremor, numbness. Review the imaging with the same thing as I've said multiple times. Finding something on imaging does not mean you've identified the singular cause of the pain. It means you found an abnormality. And then having a provisional diagnosis and at least attempting and starting to treat something is always a good place. And as always, be alert for red flags. So what is successful treatment of chronic low back pain? When patients were studied, they said a 30% resolution made it worth going for treatment. That being said, a lot of patients say they want 80, 90, 100% resolution. 4 minutes left. For the drugs for chronic low back pain, when you review these different families and classes, acetaminophen has low quality evidence. Non-steroidal drugs are barely better than placebo. Muscle relaxants have short-term relief, but high side effect. Benzodiazepines have no long-term data. Antidepressants used for chronic back pain and the serotonin reuptake or norepinephrine reuptake inhibitors have slight of an effect, but SSRIs and TCAs have less evidence associated. Gabapentin and pregabalin are slightly better than placebo, but that being said, it's also associated with side effects. Opioids have stronger effect than a placebo, but there's also significant side effects. I have an alert that says it's going to cut me off in 4 minutes, so I'm going to try to go through this a little quicker. There's physical modalities. Physical therapy has a lot of variability depending on which PT you go to, but there's strong evidence behind it. Massage has short-term benefit, but no sustained benefit. Traction has little to no impact on pain. Chiropractic has a small effect, but again, a lot of variability between practitioner. TENS units have conflicting evidence. Lumbar support has no evidence of benefit, and exercise therapy is well supported for improving pain and functioning. There are needle treatments like acupuncture, which is shown to benefit immediately, but not long-term. Trigger point injections have low amount of evidence studying its efficacy and even less studies looking in people with chronic lower back pain. We truly need more long-term data for it. And then prolotherapy, which is injecting hypertonic dextrose or phenol into these tender areas to stimulate irritation, inflammation, and healing, don't have studies supporting that they're any more effective than normal saline. There's nerve blocks. The idea that you block the nerve, the pain gets better. That nerve or that area was responsible for your pain. And there's a whole conversation that those joints of the back, the zygapophysial joints, used to be thought as the primary cause of back pain. But a lot of those studies looked at 50 to 80% relief, saying that's successful, that's it, that was the cause of your pain, and kind of just ignored the remainder. So treating these joints leads to a complete resolution in pain in only around 5% of patients. So that's saying it may not be as common of a cause as previously thought. So there's the lumbar medial branch blocks, and an interesting study that I've always loved with that showed the level of depression and anxiety associated with the patient and their presentation predicted the outcomes for the blocks. Again, this is a single study, and there always needs to be more evidence and more workup. Other considerations for medial branch blocks is by blocking the nerves, we could be denervating one of the large muscles of the back called the multifidus. So every time we do one of these blocks, should we be pairing it with physical therapy? There's a company called Reactivate who also focuses on this specifically. Other diagnostic nerve blocks, 20% of patients have been thought to have this back pain be traced to their sacroiliac joint. Again, it's more common in the elderly, and as many things in medicine, more studies are needed. The posterior sacroiliac ligaments, or this complex, also can be diagnosed by doing something called lateral branch blocks, but there's no population study, so it's unclear if we can identify what percentage of the population actually has this as the underlying cause. The internal disc disruption requires stimulating and injecting contrast under CT to look for fissures, but by definition, you're violating a very poorly vascular structure, possibly causing more damage than you're benefiting, and it's something that is not really well clearly documented as a clear pan for management. And then there's SI joint injections. So the sacroiliac joint itself is a large, wide joint. It's to the point when you're looking square onto the sacroiliac joint, you really only see, you see two separate sides of the joint at once. You see the anterior part of the joint out lateral and the posterior part more medial or towards the middle. Injecting some medication in this space is thought to treat the joint disruption. So we're gonna pick back up right where we left off, which was looking at the sacroiliac joints, a large, wide joint where the sacrum meets the ilium, thought to be contributed to at least 20% of people with chronic low back pain. It's something that can be treated with either diagnostic or therapeutic injections into this joint space, as well as other treatments, including nerve blocks or ablations, stunning burning of the nerves that are responsible for this joint, including as well as interventional surgical procedures like fixations or fusions. So the sacrolateral branch block is what I was just referring to. When you look at the sacroilium or the sacral nerves where they leave the sacral foramina right here, they're responsible for the innervation of this joint space right here of this sacroiliac joint. So the idea is numb the nerves. If the pain gets better, consideration that the structure and the joint that those nerves innervated was responsible for the pain. And it can be treated either with individual blocks, or it can be treated with something called an ablation, which is using heat or electricity to stun or sever or disconnect the communication of the nerves from that structure to the spinal cord to the brain. Psychological therapies are well supported, have significant evidence, and my favorite component of them is they have no associated side effects, medication interactions, addiction, overdose risk, anything of the sort. It is well supported with evidence. Long-term outcome data is less prevalent. Intradiscal therapies, or treating those discs between the individual vertebral bodies, either with a variety of different medications, but there are no well-controlled, rigorous studies comparing one disc treatment to the other. And then invasive treatments, such as spinal cord stimulators, intrathecal pumps, is a much more complex, nuanced discussion that I'm going to kind of intentionally skip over. And then the spinal surgery, which, at least per the discussion, current literature says that it can help in the correct patient offer greater pain relief than these conservative therapies, but there's not really good data on the success of complete relief of pain or sufficient enough to restore function and end all future interventions. And so the last line I want to end with from the chapter that I referred to in the beginning is, this is the last bit of the conversation, which is many treatments for chronic low back pain were not addressed in that chapter discussing acute and chronic back pain because there's no evidence by which currently they can be well evaluated. Yet they are still practiced. In this regard, Dr. Archie Cochran, who's the founder of evidence-based medicine, posed the rhetorical question, I wonder how many things are done in medicine because they can be rather than because they should be. And so my entire focus and great joy in what I do is helping to treat chronic pain. I think treating pain offers quality of life. And I think at the end of the day, that is what we all seek and focus on. And so my quality of life is my wonderful, amazing, funny, crazy, brilliant wife, Abigail. And she's a big reason why focus on people's quality and happiness is something that is so integral and important to my own focus and career. So thank you guys very much for those who exited and then came back and rejoined in this. I'm going to call it a multi-part lecture series is the nice way I'll frame it. It makes it sound a lot more professional. And that was right around 25 minutes. So I hope that was informative or at least interesting. And I am more than happy to answer any questions. And if I don't know the answer, I'll do my best to distract you and move on.
All right. Thank you, Dr. Peskin, for the presentation. At this point in the presentation, this is where we do the Q&A. So if you would like, I have given you the ability to unmute yourself and ask a question, or if you'd like to type it in the chat, feel free to do that as well. However, I will kick things off. I do have one question. When treating patients, is there one contributing factor that you see more frequently than others? What do you really hammer home when you see these patients? Like, what is the number one thing these people should be looking to help themselves?
Absolutely. I think in medicine as a whole, and especially pain medicine, it's very difficult to paint with a broad brush. Two people who show up with near identical complaints, one could have been a fracture or damage from years ago. The other could have been something acute from a car accident. I think the number one thing that I try to express to my patients is I see them for narrow windows of 45 minutes or 30 minutes at a time every few weeks. They are the people who wake up, live, go to sleep with this pain, taking personal ownership of your pain, whether it's minimizing things that can hurt healing or worsen inflammation like tobacco and smoking, whether it's things like not getting deconditioned and exercising, engaging fully with physical therapy. If you're doing physical therapy, don't just do it the 2 1-hour sessions a week. Try to engage it as part of your nightly routine for 15 minutes.
Absolutely.
I think contributing to your own wellness and your own healing journey is the best thing I can try to offer.
Got it. Yeah, I agree. Thank you. Any other questions at this time? Let me check the chat here. Right. Just another minute here.
I appreciate everybody listening and participating and joining, exiting, and rejoining. It's very nice of you. Very appreciated. And I am super happy, willing, and enthusiastic to discuss any of these topics at any time. So if something's on your mind, if there's a question, please definitely let me know. I'm very grateful that I'm here at Insight, and I see wonderful things that we can do.
Absolutely. Well, if you guys haven't got the chance to introduce yourself to Dr. Peskin yet, I encourage you to do so. Great guy, clearly knows what he's talking about. If any questions come up, I'm sure he'd be happy to answer them in passing. But if that's it, then thank you, Dr. Peskin, for the presentation. I apologize, everybody, for the technical difficulties, but it looks like we still ended up with a pretty good turnout. Enjoy the rest of your day, and we'll see you in about a month.